So the potential areas for error. It can be the name of the prescribed drug. I've seen all sorts of creative ways of writing common drugs and not actually using the correct spelling. And some of those can actually be quite similar. It'd be worth having a look in the B&F. Just take a few minutes to have a look in your B&F and see if you can find some drugs with very similar names which could be miswritten or misspelt, or if not read, not very legible, could have been misinterpreted for the wrong drug. Sometimes writing abbreviation of the name. So that's why it's encouraged to use the approved titles and ideally generic. Sometimes it's not appropriate to write generically because you may want a specific product which you know has particular properties. It may be a modified release, slow release preparation. It may be a particular dressing. It may be to do with compliance because a patient who's elderly may not understand why every month they get a different coloured tablet. So you may choose to prescribe a particular product by brand name to increase compliance or for the particular properties that drug has or product has. Formulation. So it's important you write the formulation because if you think of all the routes for medication, all the types of formulations, there's so many, and you may want to specify one. You need to think of the pharmacodynamics and pharmacokinetics in terms of the formulation as well, and the effect you're trying to achieve. And this may interlink with the age of the patient as well. The strength, if any strength as well, must be specified, and the dosage, of course. These sound so obvious, these things, but I can assure you when I've been marking prescriptions for students' final assessment, some of these things are omitted. I've even had in one case the name of the drug omitted. Everything else was correct, but they didn't actually write the name of the drug on the prescription. Just in nerves, but again, that's when you're quietly preparing for an assessment or a piece of coursework to hand in. But when you're in the cut and thrust of the workplace or patient's home, even more chance for making errors. So you need to really get very, very slick at your prescription writing and making sure you always have a system that you include all the elements you need to include. Another area for errors is writing unnecessary decimal points. So for example, 5 milligrams shouldn't be written as 5.0 milligrams because, well, you think what could happen if you wrote it that way? Yes, someone could not see the dot. The dot's not properly clearly dotted and could look like 50 milligrams. Horrific consequences. If it's unavoidable, a zero in front of the decimal point, e.g. write 0.5 mils but not 0.5 mils. So if it's a small dose and you want to write half a mil, so 0.5 mils, there you need to put the 0 in front. That makes it clear because again, if that dot's not clear, half a mil can become a 5 mil dose. It is acceptable to use a decimal point when you're expressing a range, for example paracetamol. Rather than writing 500 milligrams to 1000 milligrams, you can write 500 milligrams, sorry, 0.5 milligrams or 0.5 grams to 1 gram, so 0.5 to 1 gram. The frequency should be put in. If you're writing something PRN, which is its acceptable Latin abbreviation to use, and if you look at the inside cover at the back of the B&F, you'll see the Latin abbreviations which are acceptable to use. Make sure you only use the ones that are allowed. Don't come up with some creative ones of your own. If a PRN drug is prescribed, what additional information do you think should be written on there? It may be that it's something for pain, for example. It might be ibuprofen or paracetamol, for example. So you may want to specify the maximum dose, yes, but if you don't put another piece of information on, that still is very unsafe. And the piece of information that must always go on a PRN prescription is the minimal dose interval. For example, if you wrote a prescription for 500 milligrams of paracetamol and you just said PRN, maximum 8 grams in 24 hours, technically you could prescribe 500 milligrams every 5 minutes, which we all know would be highly dangerous and cause severe consequences for the liver. So think about why PRN dose must specify the minimum dose interval on your prescriptions, and it must always be included because it's dangerous if it doesn't. You need to also specify the quantity and duration of treatment. It's normal practice now for most drugs to be prescribed for a maximum of 28 days. There may be exceptions where for a longer period it might be, for example, the contraceptive pill you may want to prescribe for 6 months, etc. But usually practice tends to be 28 days. You need to check with your particular PCT if you're working in the community, because some trusts have actually specified all their prescribers write prescriptions for no more than 28 days. Some recommend and some still can be variable. So you need to be clear what your local policy is so that you're complying with that as well, because it has implications for the prescribing budget. Think of another reason why it's good practice to only write prescriptions for 28 days. We've talked before in the first lecture about patients not complying with medication. It can be patients stockpiling. If you're writing things regularly, or you may write for 3 months worth or 6 months worth, and the patient after a week doesn't like the drug and they stop using it, they've got all that medication and wasted medicines. It's costing the NHS billions of pounds. So writing for 1 month at a time, yes, it's not very popular with patients, because particularly if they're paying for their own prescriptions, means every month there's that item they have to pay for each time, whereas if you wrote for 6 months they'd pay for it once. But there are other ways in terms of prepayment certificates, etc., or if they're eligible for free prescriptions. So you need to be clear about the amount that you prescribe, and it's the right amount. You don't under request an amount. You calculate correctly the amount of mils or the amount of tablets you will need to complete a course of treatment that you've prescribed. So we've not left grams, milligrams and micrograms completely behind, I'm afraid. That was just the tip of the iceberg before. So quantities of 1 gram or more should always be written in grams. So you'd always write 2 grams. You wouldn't write 2,000 milligrams, for example. Quantities of less than a gram should always be written in milligrams. So you'd write 500 milligrams, not 0.5 grams. I know we said there was that exception where you're putting a dose range, 0.5 to 1 gram for paracetamol, for example. But if it's a single dose, you'd always write it as milligrams. So you can abbreviate milligrams and grams as written on the slide, but when you get to quantities of less than 1 milligram, your writing for micrograms or nanograms must be written out in full. So think of micrograms. What's the risk if you just wrote mcg? That can be mistaken for milligrams. So it's good practice and safe practice to write micrograms and nanograms, any other small microscopic amount in for full words, so it's not confused and it's clear and can't be misinterpreted. The word units is another big area for problems. That should never be abbreviated. It stands for international units, so you might see someone write IU for international units, but what could that be misinterpreted for? Depending on your handwriting, it could be seen as IV. It could be seen as 10. If you put a U, if you join up the U almost to a circle, that could be seen as a 0. So the implications are catastrophic, so always write the word units in full. Calculations should be double checked. Different parts of the country have different practices. Some people use calculators, some people do it by longhand. The caution with calculators is to remember that if you put the wrong information in, you'll get the wrong information out and you may not know that it's the wrong information. If you do it longhand, you can double check and work your answer back to the original answer. So it's something to bear in mind. And there is research to show where people previously didn't use calculators in terms of numeracy tests, and then calculators were introduced, the failure rate went up by something like 25% or more. So they can be a serious cause for error, and also unnecessary security that the calculators must make the calculation right, which isn't the case at all in practice. And I think, as we've mentioned in the first lecture, always reread your prescription when you finish, particularly if you've got distracted halfway through. It's good practice. Before it leaves your hand, make sure you've read it after you've signed it, whether it be electronic or handwritten, hospital or whatever type of prescription you're writing, private prescription or whatever. I can give you some examples of errors. A prescription written in a nursing home for 6 units of insulin was written as 6 IU, international units. So they wanted 6 international units of insulin, but the person administering the prescription read that 61 units. So the patient received a 10-fold dose of insulin and was admitted to hospital. That was in 2001. And I'm sure you've heard of cases, either in the media or maybe even where you work, of similar tenfold errors. And tenfold errors are very common, and it's often just to do with this issue of decimal points, either not writing units in units, or inappropriate use of zeros, for example, as well. The second case study, a patient was given Losec instead of Lasix. So that's an example where a drug name is very similar, and if the writing isn't very readable, it can be misinterpreted. And what happened in this case is a 59-year-old who suffered a cardiac arrest due to low serum potassium levels, so horrific consequences just through an illegible prescription. And the person reading that prescription has accountability as well as the prescriber, because they administered and weren't maybe not clear and assumed that it was one particular drug rather than the other, and didn't double check with the prescriber. If you're writing a prescription in hospital, you need to include the name of the prescribed item, the formulation, the strength if there's any, the dose, the frequency, and if there's a defined length of treatment time, this should also be stated as well. And if you're writing for an outpatient or discharge for patients, your requirements are the same as for community nurses writing on FP10. You need to be familiar with that. When you're writing the medicine's name, as I've already said, you must be clear about using the approved generic titles where possible. They're specified in the BNF, the MPF if you're a V100 prescriber, in a children's BNF, and it shouldn't be abbreviated. We've said about exceptions if you want a particular product. Another area would be if you're prescribing for nicotine replacement, for example. You may want to put the product name. For example, if you wanted to use a transdermal patch for nicotine and you wanted one for someone who's a lady, for example, who's very conscious about it being seen, you may choose one that's flesh coloured rather than one that's a clear film. They may prefer that, or they may think the clear film looks more natural than the one that looks flesh coloured. So there are cases, and you need to justify your decision for that and record that, because someone following on may not understand why you've prescribed non-generically. So your rationale needs to be clear in your record keeping as well.